Hello, hello. How are you guys? Happy Friday. It's a gorgeous, almost spring Friday here on the East Coast, and I am loving the weather. I am coming to you live to do a live with Dr. Nicole Browne. She's the newest doctor at Rejuvenating Fertility Center. We're going to talk all about adenomyosis or adenomyosis to really give you guys more information on this condition and how it's impacting your fertility. So I'm going to bring Dr. Browne on now with me. Dr. Browne, I think I see you there. So what I want you to do is, let me see if I do this. Oh, I'm going to invite you to join, Dr. Browne. So you should see something pop up on your, let me see. Why don't I see you? Let me just see. I'm going to click your name. Huh. Dr. Browne, are you still here watching? Because I don't see you on my viewers. Let me see. Oh, you did it. Technology. It's not always everybody's strong suit. Let's see that it works. I've accepted her to join me live. Let's see. Oh, it worked. Look at that. Now turn your phone around so we can see your beautiful face. Let's see. Now I just see. There you are. All right, you did it.
How are you, Amy?
I'm good. How are you?
I'm doing well. Good to see you.
You too. Are you at the clinic right now in Connecticut?
I am. I'm here seeing patients today.
Yeah. So she took a break out of her very busy doctor schedule to come and discuss, do you say adenomyosis or adenomyosis?
I say adenomyosis.
Yeah, that's what I say, adenomyosis as well. So we were just talking briefly on the phone before we went live, and my first question to Dr. Browne was, or comment, I was like, I feel like I'm just seeing so many more women being told that they have it more than ever before. And I asked you, do you think we're getting better at diagnosing it, or do you think it's been there all along? And I liked your answer. If you remember, you said about endo. So go ahead and share.
I think, for a long time, endometriosis has been underdiagnosed, but you'd be surprised, Amy, by how many women actually have endometriosis. And I think because we've gotten better at diagnosing endometriosis, we've now sort of keyed in on or honed in on adenomyosis too, which can affect fertility.
Yeah. And so tell us, what is adenomyosis?
Sure. So adenomyosis is actually a common gynecologic condition that affects a lot of women of childbearing age. And so, Amy, adenomyosis is just endometrial tissue that lines the uterine cavity, but it gets displaced into the muscular wall of the uterus, and it grows. And it's hormonally responsive, so it responds to our monthly hormones, just like the normal endometrial tissue in the uterine cavity. And it can grow, and it can shed and bleed into the muscular portion of the uterus. So you can only imagine, Amy, how painful that can be. And it can contribute to a lot of significant abnormal bleeding.
And then also implantation issues, right? Because that patch of tissue, if you will, or adenomyosis is not implantable. That's my thinking. Is that correct thinking?
That's correct. So remember, adenomyosis is normal endometrial tissue that should actually be in the cavity of the uterus, but now it's growing into the wall of the uterus, and that's not where implantation happens. It should happen in the uterine cavity. So implantation can't happen in the setting of adenomyosis or lower implantation.
So it's almost like if that's the uterus and that's the lining, then adeno is kind of like happening like in here or something like that. Is that kind of what it is? It's going into the muscle layer?
That's exactly right. That's exactly right.
And so then this whole patch is like, sorry, nobody can live there, basically, because, right?
You can think of it that way. Yes.
Yeah, I've described it before, but I think I'm wrong in my description. The way I picture it in my head is almost like I say this, like a patch of desert in the uterus where it's just like, sorry, nothing can live here. It just can't implant. But it's maybe desert isn't the right. It's like kind of like a patch of a jungle almost. It's kind of more like it's chaotic, if you will. Like it's in the muscle. And that also probably causes the uterus, I'm sure, to cramp and maybe be somewhat distorted in its shape, right?
That's exactly right. And actually, everything that you just said, Amy, are some of the reasons why we think that implantation is lower in women with adenomyosis. One, potentially can distort the uterine cavity. So it can interfere with the interaction of the sperm and the egg and the subsequent movement of the embryo into the uterus. There's also some thought that there's abnormal steroid production in the endometrium of women with adenomyosis and abnormal steroid hormone receptors. So the response to hormones can be exaggerated, especially with the hormone estrogen in the setting of adenomyosis, and that can
So is
affect
that like
implantation.
when like I just had a woman who I have to think of the exact case. I think I was talking to her yesterday. I'm like you sometimes where I'm like, I have so many cases and I remember the cases, but I like to be able to picture the person. It helps me tell the story. But anyway, she was saying since doing rounds of fertility treatments that have not worked, unfortunately, now her period is like super heavy and painful. And that's made one doctor think that it was endometriosis, that like basically the stim meds have exacerbated the endo. But would you also then say, well, maybe that's reason to think for adeno as well, or we would
For
just
sure. For sure. The symptoms associated with endometriosis are pretty similar to those associated with adenomyosis because adenomyosis, remember, Amy, is endometriosis. It's just tissue. It's endometriotic tissue growing in the wall, the muscular portion of the wall of the uterus. So it behaves just like endometriosis. But then you also have to rule out other factors that can sort of mimic the same symptoms as endometriosis and adenomyosis, specifically uterine fibroids. Okay.
or myomas or something like that, right? Like,
Exactly.
yeah. And so what do you think is the best diagnostic tool for endo or adeno?
Okay, so I guess, Amy, after taking a thorough history and performing a pelvic exam, because sometimes on physical examination, the uterus is enlarged in the setting of adenomyosis, and it can have a globular shape to it, a globe-like shape.
Like this
And
instead of like more of a heart-like shape, right? Like,
exactly.
yeah. Okay.
Exactly. And so after taking a history and doing an examination, then what we would recommend is doing a pelvic ultrasound. And you can readily do a pelvic ultrasound in a fertility doctor's office. But on ultrasound, some of the things that we're looking for is asymmetry between the top and bottom wall of the uterus. You can see that with adenomyosis. Sometimes you can even see striations from the lining of the uterus going into the muscular portion of the wall of the uterus. And you can also see sometimes cyst-like structures in the muscular
Almost
portion of the uterine wall.
like, and they're like kind of long, right? They're not like round. They're like these elongated ones. And then so the striations would be differentiated because it's not trilaminar, right? Is that like we're typically looking for the trilaminar?
You can have a trilaminar appearance. You can also have a very heterogeneous lining or a homogeneous lining to the cavity of the uterus, but it's pretty significant when you start to see this linear striation go from the endometrial lining into the muscular wall.
Like goes in
But
deeper almost.
goes in deeper. Exactly. You can think of it that way. But I think the best imaging modality is going to be an MRI because you're specifically looking for a thickening of something called the junctional zone.
Yeah.
And the junctional zone is the interface between the lining of the uterine cavity and the inner portion of the muscular wall of the uterus. When the junctional zone is thickened, then that is usually evidence of adenomyosis. So MRI is really the best imaging modality to make the diagnosis.
Cool. And so, so, and then I just want to clarify what I'm hearing because I've always seen them as two separate, but adeno is basically endo, but in the
Mhm.
muscle layer. So can one exist without the, I know we can have endo and not have adeno, but can we have adeno and not have endo?
You sure can.
Yeah.
You sure
Okay.
can. Uterus, yeah.
So, does it create, so I would, we know adeno and the presence of it obviously is going to could change the structure of the uterus, would also impact implantation. Will it cause, or does it cause an immune response in the uterine environment, or is that again like hard to say generically, if you will, for everyone?
Good. Okay, so with endometriosis, and remember, adenomyosis is just a form of endometriosis, it creates an inflammatory environment. Okay, so there's an abnormal inflammatory response in endometriosis, with endometriosis and with adenomyosis, in part because of a specific type of white blood cell called macrophages. Yeah. And when these macrophages are activated, they release a lot of pro-inflammatory markers. Okay?
Yeah.
Yeah. And those pro-inflammatory markers can increase free oxygen radical species that can affect the egg, the sperm, and the embryo. So you can think of these inflammatory markers as being toxic to all three of those things. So yes, adenomyosis has a very heightened immune response.
Yeah. And then you've just made me want to ask this question, which I didn't tell you I was going to ask you, but in response to that free radical, like, uptake, or uptick due to the endo or the adeno, we could then say, bear with me, that not all your eggs are bad, but the environment in which they're being fertilized or growing could impact the quality versus, the story, you do this for a living, most women are told, oh, sorry, it's just all your eggs are bad. And no one's really considering how the environment is impacting egg and sperm quality as they implant and then develop. So I guess, and if I'm stretching, I don't want to put you in an uncomfortable position, but I'm more just thinking the endo and the adeno.
Amy, I'm
frozen. Hopefully. Yeah. Can you hear me? Yeah. I froze, or did you freeze? Did you get all that? Or no, because you were frozen.
No, I can hear you now. I can hear you now. I heard some of that, Amy. And I think to answer your question, you're right. And we know that egg quality, fertilization, and implantation rates are lower in women with endometriosis. And you're probably right. It's probably due. There is a component that is due to the abnormal immune response associated with these conditions.
Yeah. So it's just to say, like, I just think more that blanket response, like all your eggs are bad, is more like, well, but we haven't really looked at the environment. And shouldn't we, I don't know, I know my work, right? We're really focused on lowering inflammation, regulating the immune system, improving uterine blood flow, right? So to improve the environment, which then, like, from what I can see, improves pregnancy outcomes. And so is the work, and I will never quite know, but it's like, is the work improving egg quality and embryo quality, or is the work actually improving the environment, and then the embryo now has more of what it needs to survive versus because it's the endo and the adeno, I think, create more of like a toxic environment. That's how I would just kind of generally see it.
I completely agree.
And so then if you suspect, your first line of like next steps would be pelvic MRI, not lap.
Not a laparoscopy. I think, surgery is a last resort for adenomyosis, especially for patients wanting to have a child, because the only way to ultimately treat it is a hysterectomy. So that's not going to be an option for patients wanting to have children.
Yeah. I just had a patient that, now I'm remembering the story that I was sharing before that I couldn't remember. I just had a patient too who she was told by this doctor, we suspect endo and maybe adeno based on your poor response to the fertility treatments. And it was pretty high stims. Like they were giving her like 300 gonal and priming her with estrogen and things of that nature. And the doctor said that she would do a lap plus go into the uterus and remove some of the adeno. And I had like this. I was like, don't touch your uterus. And she's like, and then it would be a 6-month recovery. Then you could get pregnant. And I was like, I would not do that.
I agree.
You agree? Like I would go and do the lap, remove the endo, and then do suppression for 2 months, right? And and somewhere in the middle, do a retrieval or two to collect some embryos, right? I mean, I guess, yeah, what would you do in a case like that? How about that?
Good. So I completely, doing a little laparoscopy to address any endometriotic implants to try to lower inflammation is fine. Okay, prior to the start of an IVF cycle, I do suppression therapy after a patient banks embryos. Okay, because the suppression therapy, I usually recommend 3 months of Depo-Lupron before undergoing a transfer to really quiet down the inflammation associated with adenomyosis and even endometriosis. We were talking before, Amy, about altered hormone production and the responsiveness of the endometrium to more estrogen production in the setting of endometriosis and adenomyosis. So this is where hormonal suppression really comes into play. People have looked at this and they've seen higher pregnancy rates in the setting of adenomyosis after doing 3 months of Depo-Lupron. Again, because we know it's a hormonally responsive disorder, we know that the higher levels of estrogen can also affect receptor expression in the lining of women who have adenomyosis. So this suppressive therapy with Depo-Lupron a few months before undergoing an embryo transfer can actually help with implantation and potentially even lower miscarriage rates. So it's a hormonally responsive disorder. So, suppressing it with hormones is key.
But you want to be careful with the suppression, I guess, especially in our later 40 girls, because we could put them in suppression. So suppression basically means we're putting you kind of into menopause, if you will. That's what you would maybe in the layman's terms see it as, right? That we're suppressing all of your hormones so that this stuff stops growing. The uterus has time to heal and then become, I guess, healthier, that then it can receive the embryo. Some doctors are concerned, and I've had plenty of patients go through it where I've never had a patient not come back, though I will say that. Like, I've never had her not come back to cycling. Even I just had one, I just did a story of hope. She's 45. She has a 5-week-old. She did suppression. Her period came back. Like, she's still in the game, if you will.
It's like a pseudomenopausal state with Depo-Lupron. And, definitely not true menopause, pseudomenopausal state. And this is why I encourage patients to bank embryos before being committed to this 12-week course of Depo-Lupron. To really make sure that they've amassed a certain number of embryos before they're ready to undergo a transfer, because the effects of Depo-Lupron can stay on for a couple of months after the last injection.
Okay. And so then, in your opinion, do you push for the endo surgery for the lap, or do you just prefer suppression across the board?
Good. I think depending on symptoms. So if you have a patient who has excruciating periods and they haven't responded to hormonal treatment in the past and they're looking to get pregnant, I don't think it's a bad idea to undergo a diagnostic, possible operative laparoscopy to remove any endo, because again, it creates an inflammatory condition that can affect implantation. So I recommend surgery in that setting, and then going right into a treatment cycle followed by a course of Depo-Lupron before undergoing a transfer.
And then, I just had another question. What was it? It escaped me. So in the endometriosis setting, like say we see an endometrioma or something like that, I think it's a little more obvious, like, okay, there's endometriosis here. This is the question I had. So what about women who say are making genetically normal embryos, healthy embryos, they have a good reserve, not getting pregnant, right? We're transferring, we're not getting pregnant. Would it be, I mean, would it be something that you'd go in and try to rule out adenomyosis, or recommend, like, so would you then go to a pelvic MRI? Do you think it's always showed up on a pelvic MRI? Like, there's no way it's to be missed on a pelvic, or can it be missed?
It potentially could be missed, but MRI is a pretty sensitive imaging modality. But what you're describing, definitely a possibility. What you're describing sounds like recurrent implantation failure where, let's say no concerns about egg quality, sperm quality, or even embryo quality, but for some reason, a couple, they're just not getting pregnant. And you're right, because there's no general consensus on what causes recurrent implantation failure, but adenomyosis should be included in the differential. And so at that point, yes, you're right. I would spend time studying the uterus. Okay, and there are different ways to study the uterus. There are many endometrial function tests that allow you to look for specific receptors that are absolutely necessary for implantation to occur. And we do know in the setting of adenomyosis that there's lower integrin receptor expression.
Integrin B, right? Isn't that it? Yeah.
Exactly. And without integrin receptors, even the most beautiful embryo won't implant into the uterus. And dapiglutide has been shown to potentially upregulate those receptors.
Yeah. And then what are some of the other endometrial function tests that you like to run?
I will also do an ERA study. I think there's utility to doing ERA for some patients, but I do Receptiva and ERA.
Okay. What about the analysis? What do you think about that? I know it's not really pointing us to endo or adeno, but do you see utility in that test?
I haven't used it.
You'll do the endometrial biopsy though to rule out endometritis.
Oh, I'm so sorry. I didn't hear what you said, Amy. Endometritis. Yeah. So actually, as part of the Receptiva assay, that's one of the things that is screened for endometritis. It's very treatable, and we treat it commonly with doxycycline for a couple of weeks.
Yeah. So if we're having repeat implantation failure and there's no other concerns, if you will, I think, looking at the uterus is a smart thing to do. And then let me just see. I know we had a list of questions. I was saying at what point do you put somebody in the repeat implantation failure category? Is it like 3 transfers of healthy normals, or I don't know? You tell me.
So there's no general consensus on the definition of recurrent implantation failure, but I think it's fair to say that if after 3 failed attempts of a transfer attempt with high-grade embryos, you probably have the diagnosis of recurrent implantation failure.
And then I also know, I know the practice you work with, and I know Dr. Murphy and Dr. Marco's, if you will, like their standard operating procedures. They're big fans of the hysteroscopy, right? And do you feel similarly? Like for me, on my side, I think we look at it very similarly. We've had many conversations about this, but every embryo you work your ass off to create, I think, is highly valuable and really important. So before we go and do a transfer, right, I'm a big fan, especially if there's been no pregnancies, especially I see these cases a lot, right? They have a baby. Now they're trying secondary infertility. They're not getting pregnant. I always think we should probably check the uterine cavity because isn't that, but then also we have these women with unexplained infertility and they've done all the things and still, 5 IVFs later still hasn't worked. I guess, just discussing, and I believe you're in agreement of doing those endometrial function tests sooner than later in a lot of cases. Would you agree? Yeah.
Definitely. Amy, the uterine cavity, we can't forget that the uterus does play a role in our ability to get pregnant and to stay pregnant. So you always want to evaluate the uterine cavity, whether it be a water ultrasound or a hysteroscopy, because remember, what someone may call normal, there could be an abnormality that just wasn't detected, but could put you at greater risk for a miscarriage if it goes undetected. So for sure, evaluating the uterine cavity with a hysteroscope is never a bad idea.
Yeah,
especially in the study
I
of
feel
recurrent implantation failure.
What I've seen on my side is the saline sono can miss what the histo typically doesn't miss, right? You would agree, I think. The histo is, you have to go under anesthesia. It's a much bigger procedure, right? I get all that. To me, the pros far outweigh the cons. That's typically what I say. Someone just asked that, one question was, can an MRI diagnose endo? And I believe the answer is yes. A pelvic MRI is another way to diagnose the endo besides a laparoscopic surgery.
Sure. So That's correct. So if you have severe stage endometriosis, chances are it's affecting nearby organs like the ovaries. So you can get an endometrioma, which is endometriosis in the ovary that forms, and that can determine the diagnosis of endometriosis.
Yeah, yeah. And then someone else said that their doctor was recommending Orlissa. How does that compare to Depo-Lupron?
Okay. So Orlissa is a GnRH antagonist, so it also suppresses the ovaries. And remember, estrogen contributes to the growth and development of endometriosis and adenomyosis. So potentially Orlissa and Depo-Lupron can be effective here to really shut down the inflammation associated with adenomyosis and endometriosis.
But the research has been mainly on the Depo-Lupron for implantation failure, which is why I think that's the default. Yeah.
That's exactly right. And the pregnancies have been reported with Depo-Lupron.
Yes, exactly. But side effects are about the same. Like, they can't be very different, if you will. They're both going to do that pseudomenopausal thing, which, by the way, I'm going to use that term forever now, pseudomenopause, because, you know, in our world, the word menopause scares the shit out of all of our girls, you know? Yeah. Although you guys are rocking that boat a bit, which I love. Okay, so let's see. So anything else you want to add that you think is important for girls to know? Like if they're maybe thinking, oh, maybe I do have adenomyosis. I mean, I think I guess this is one more question that I have. Could a woman have adeno or endo, which I know they're of the same, you know, root, and not have heavy, painful periods?
You can. I mean, there are women who have advanced stage endometriosis and they never knew about it because they were always asymptomatic. So yes, it is possible. I think, you know, Amy, I would just encourage women to remember that the uterus does play a role in our fertility. You know, I think we spend a lot of time talking about the egg and the sperm and the embryo, but don't forget the uterus. There are endometrial function tests. There are things that can be done sooner than later to try to establish the diagnosis of adenomyosis. And if it's present, you definitely want to treat it to increase your outcomes.
Yeah. And I see it a lot, you know, and I know you guys do too, because you're getting girls that have been at other clinics where doctors are just refusing to do those uterine function testing, or refusing to do the hysteroscopy, they say there's not enough data to support looking for the endometritis and treating it. And I see it as a big part of my job of like arming them with the script or with empowering them to go get another opinion then. But I don't know, what would you say to women that are facing those challenges with their doctors?
Keep advocating for yourself. And we are here at Rejuvenating Fertility Center.
Boom. Yeah, that's it. Yeah, because you're a huge advocate for women, which I mean, I appreciate so much. I mean, all of our, it makes me like, I could cry right now saying it, but it's just like you guys fight for women in such a beautiful way. And it's devastating to see where I think it's fairly obvious that it's a uterine issue. But yet the blame still falls typically on the woman, regardless of her age and her egg quality, you know? And so,
exactly right.
Yeah, we're here to move the ball forward and empower you guys with the information so you can ask the right questions and get to the bottom of it. Yeah. And I think it's just keep pushing and advocating. And then also don't forget to get other opinions, you know? And then someone commented, go to RFC. They're the best. My baby is here because of working with them and with Amy.
Oh, thank you so much. That means a lot.
Okay. This was so lovely. I loved doing this. We'll have to do more of these. Do you have anything else you want to add, or you feel good? I feel like we covered a lot.
I think we did. I think, you know, patients should be well informed after our talk today about adenomyosis, fertility, and recurrent implantation failure, Amy.
Yeah. Okay. This sounds great. Thank you so much, Nicole. Go enjoy the rest of your day. I'll probably see you. I think I'll be in on Friday. Oh no, today is Friday. I'll be in on next Friday. I'll see you then.
Looking forward to it.
Okay.
Have a nice weekend.
Bye. You too.
Bye-bye.
Bye, everyone. Thank you.